Smile is powerful, universal. Smile is infectious. It spreads happiness and hope around us. And behind every smile, there's health. Our commitment is to ensure that.
Aurobindo, committed to healthier life. Headquartered at Hyderabad, India, Aurobindo Pharma began its illustrious journey 3 decades ago as an active pharmaceutical ingredient manufacturer and soon became renowned in the US and Europe markets with specialty generic formulations, with supplies to over 150 countries. Today, Aurobindo is a global company that is ever evolving and ever expanding.
Our corporate mission is to offer world-class quality medicines at affordable prices across the globe with ever-expanding manufacturing and research capabilities.
In a world where modernization is manifesting in many ways, managing our health is turning much more complex despite the availability of high-end technologies. And to consistently create best-in-class therapeutics is always a challenge that Aurobindo's acclaimed team of over 800 scientists look up to. Pharmaceutical innovation is much more than a necessity. It is a responsibility to bring to light novel therapeutic solutions for better patient care, and that too in a cost-effective way. And our state-of-the-art research and development facilities stand a testimony to this.
Located in Hyderabad, the centers comprise of the Analytical Research Wing with sophisticated instruments to test the quality and stability of various drugs, and the Chemical Research Wing to resolve the challenges of complex chemistries. While our chemical scientists develop patentable processes for APIs, our formulation development specialists apply new technologies in dosage formulations and develop novel drug delivery systems. The large number of patents truly demonstrate our R&D strength. In the unmet needs of patients, Aurobindo sees an opportunity for research breakthroughs. Setting up of a facility for complex peptides and orozymes is one such bold step in this direction.
Orozymes is the biocatalysis function of Aurobindo. By using green technology, we develop scalable biocatalytic processes and thereby reduce the cost of manufacturing.
In line with the growing need for large talent pool, Aurobindo has also set up ATDC, a specialized training center to develop and hone the professional skills of its personnel.
Beyond research, Aurobindo's production capabilities continue to play a key role in shaping up the enviable reputation of the company. Today, Aurobindo Pharma is a $2 billion pharmaceutical powerhouse and has large manufacturing facilities for APIs and formulations globally. The facilities conform to CGMP norms, ICH guidelines, and are approved by stringent regulatory authorities globally. Aurobindo has a product portfolio of over 200 APIs and more than 400 finished dosage formulations spread across major therapeutic categories encompassing antibiotics, antiretrovirals, cardiovasculars, drugs for central nervous system, and niche therapeutics. With a large portfolio of antiretrovirals, Aurobindo also joins the elite few as the most preferred and amongst the top 5 global suppliers of ARVs to reputed funding agencies for AIDS relief globally. The API manufacturing facilities at Aurobindo are well equipped with modern reactors, capable of handling high reaction volumes and are automated with closed transfer system for manufacturing the latest and high potency APIs. Aurobindo is a vertically integrated manufacturing company, producing finished dosage formulations from its own APIs, offers a clear-cut advantage of cost-effective medicines backed by a distinct hallmark of quality. Aurobindo also holds a distinction of being the largest manufacturer of oral solid formulations like tablets, capsules, and powder for oral suspensions, besides injectable preparations. To cater to high demand in the parenteral segment, Aurobindo has an ultra-modern facility exclusively for both small and large volume steriles like specialty injectables, ophthalmic solutions, inhalation solutions, and lyophilized powders. The facility also specializes in novel technology platforms such as blow-fill seal, pre-fill syringes, and form-fill seal that are soon becoming the new delivery standards for supplies to hospitals and health centers in the global markets. When it comes to adapting modern technologies into its infrastructure, Aurobindo is always at the forefront. The facilities are equipped with closed material handling system to minimize powder spillage and maintain product efficacy. The warehouses are installed with automated storage and retrieval system, a computer-controlled robotic technology for efficient and error-free storage and transfer of material.
As the capacities continue to expand, expertise in packaging is another critical factor governing the entire process. Our fully automated packaging lines with ultra-modern monitoring systems ensure strict control over quality. Today, patients have come to equate the name Aurobindo with quality and, more importantly, with trust.
In its approach to business, Aurobindo integrates a robust and sustainable safety system.
Forming the backbone of the company's differentiated product mix is a regulatory team comprising of seasoned professionals to help build an enviable product portfolio and scale the value chain.
Around the world, more than 11,500 employees work relentlessly to innovate and bring to life therapeutics that enhance healthcare.
And Aurobindo's quest is to be a stronger and more knowledge-driven company today than yesterday. Aurobindo not only promotes innovation, but also fosters an environment that is both engaging and energizing to their employees.
Aurobindo Pharma is a truly global company in all respects, with revenues of over $2 billion. Today, Aurobindo has a significant presence in the highly regulated markets of the US and Europe. Aurobindo's US subsidiary operates 3 world-class facilities.
Through the combination of Aurobindo's vast India manufacturing base with rigorous global quality standards and commercial and distribution expertise, we've delivered superior customer service, resulting in growth to become a top 10 pharmaceutical supplier in the United States.
To expand its robust portfolio, Aurobindo recently acquired Natrol and to further its formulation business in the Western European markets. Aurobindo has also acquired key business of Actavis in Europe. The avenues for Aurobindo's growth in the near future have already been mapped with new therapy initiatives, and the company will soon foray into peptides, complex oncologicals, hormonals, respiratory care, liposomal technologies, orodispersible films, nutraceuticals, and top-of-the-line OTC products, with the OTC range having already found its place in the US market in more than 10 distribution value chains. Aurobindo's growth is also the result of its research and production capabilities and its network of alliances across the globe. Besides the supplies to over 150 countries, today the company continues to emerge stronger in Africa, Asia, Middle East, CIS, and Latin America. Recognition has been the byproduct of the concerted efforts of Team Aurobindo over the years. In this illustrious journey, the company has won several awards for its innovative process patents and export performance. As part of societal commitment, Aurobindo also provides support to the neighborhood.
To the world we belong, caring all along.
Seeing health in the smiles, spreading across the miles. We are Aurobindo, Aurobindo. To make the world a better place, we commit to a healthier life. We are Aurobindo, 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 Aurobindo.
Aurobindo, committed to healthier life.
Smile is powerful, universal. Smile is infectious. It spreads happiness and hope around us. And behind every smile, there's health. Our commitment is to ensure that.
Aurobindo, committed to healthier life. Headquartered at Hyderabad, India, Aurobindo Pharma began its illustrious journey 3 decades ago as an active pharmaceutical ingredient manufacturer and soon became renowned in the US and Europe markets with specialty generic formulations, with supplies to over 150 countries. Today, Aurobindo is a global company that is ever evolving and ever expanding.
Our corporate mission is to offer world-class quality medicines at affordable prices across the globe with ever-expanding manufacturing and research capabilities.
In a world where modernization is manifesting in many ways, managing our health is turning much more complex. Despite Today, Aurobindo Pharma is a $2 billion pharmaceutical powerhouse and has large manufacturing facilities for APIs and formulations globally. The facilities conform to CGMP norms, ICH guidelines, and are approved by stringent regulatory authorities globally. Aurobindo has a product portfolio of over 200 APIs and more than 400 finished dosage formulations spread across major therapeutic categories encompassing antibiotics, antiretrovirals, cardiovasculars, drugs for central nervous system, and niche therapeutics. With a large portfolio of antiretrovirals, Aurobindo also joins the elite few as the most preferred and amongst the top 5 global suppliers of ARVs to reputed funding agencies for AIDS relief globally. The API manufacturing facilities at Aurobindo are well equipped with modern reactors, capable of handling high reaction volumes and are automated with closed transfer system for manufacturing the latest and high potency APIs. Aurobindo is a vertically integrated manufacturing company, producing finished dosage formulations from its own APIs, offers a clear-cut advantage of cost-effective medicines backed by a distinct hallmark of quality. Aurobindo also holds a distinction of being the largest manufacturer of oral solid formulations like tablets, capsules, and powder for oral suspensions, besides injectable preparations. To cater to high demand in the parenteral segment, Aurobindo has an ultra-modern facility exclusively for both small and large volume steriles like specialty injectables, ophthalmic solutions, inhalation solutions, and lyophilized powders. The facility also specializes in novel technology platforms such as blow-fill seal, pre-fill syringes, and form-fill seal that are soon becoming the new delivery standards for supplies to hospitals and health centers in the global markets. When it comes to adapting modern technologies into its infrastructure, Aurobindo is always at the forefront. The facilities are equipped with closed material handling system to minimize powder spillage and maintain product efficacy. The warehouses are installed with automated storage and retrieval system, a computer-controlled robotic technology for efficient and error-free storage and transfer of material.
As the capacities continue to expand, expertise in packaging is another critical factor governing the entire process. Our fully automated packaging lines with ultra-modern monitoring systems ensure strict control over quality. Today, patients have come to equate the name Aurobindo with quality and, more importantly, with trust.
In its approach to business, Aurobindo integrates a robust and sustainable safety system.
Forming the backbone of the company's differentiated product mix is a regulatory team comprising of seasoned professionals to help build an enviable product portfolio and scale the value chain.
Around the world, more than 11,500 employees work relentlessly to innovate.
Very good evening, Doctor. My name is Deepak Bharadwaj from Aurobindo Veritas Healthcare Limited. I take this opportunity to welcome all the delegates, all the dignitaries for attending Aurocon International Symposium on COVID Management and Expert View. Please allow me to give introduction of Dr. Khusraw Bejan, who is the moderator of the program today. Dr. Khusraw Bejan, he is the consultant critical care and head emergency department at Hinduja Hospital and MRC Mumbai. Dr. Khusraw Bejan, he is the consultant in critical care and head emergency department, as I mentioned, Hinduja as well as MRC Mumbai. He is the recipient of Lifetime Achievement Award in Emergency Medicines India in 2015. He is a co-author of Textbook of Emergency and Trauma Care published by JP in 2017. He is co-author of Textbook on Signs and Symptoms in Clinical Practice by JP 2019. He is in task force member of the Maharashtra State for COVID, and he is featured in India Today Top 10 Doctors of Mumbai in 2019, 20, 21 for internal medicine. So we welcome you, sir. So with this, I hand over session to Dr. Khusraw Bejan.
Yeah, thank you, Deepak. And good evening, friends. I hope we are all looking forward to an extremely nice program on COVID. We know that COVID has, over the last 20 months, really been a pandemic. It's called a global disaster. And now we've learned to live with it, and it's become an endemic with us, and very soon that it will be. And we also know that we cannot really beat the COVID, but we have learnt our ways of managing it and containing it, and this is going to be the new normal. So I thank you all for taking time out despite diversities and attending this, and I think this is aired all over India, and I welcome all of you all. It gives me an extreme honor and privilege to welcome and introduce our chief guest for today, Dr. Randeep Guleria. It will be a shame for me to try and even introduce him because he's known, he's a figure not only in India but world over. He's the director at AIIMS, New Delhi. He's Padma Shri and a BC Roy Award in the category of eminent medical persons. He is the director of AIIMS New Delhi, expert in several national and international forums, including the CDC, the WHO, the IAEA. He's done pioneering work in respiratory muscle function, lung cancer, asthma, and COPD. Over 400 publications, my God, in international and national journals, 49 chapters, and the list goes on. He's a member of many key committees for the government of India, and he's a dedicated teacher for over 30 years. Dr. Randeep Guleria, can we just hear it for him? And he's going to address us very shortly. It gives me immense pleasure again to introduce our chairperson for today, Dr. B.K. Rao, who's been a mentor and I can say freely a friend also for many years. I know him for about 20 years. Sir is also a Padma Bhushan recipient. He's a chairman of the COVID Task Force for Gangaram, chairman of the Institute of Critical Care and Emergency Medicine, again at Sir Gangaram Hospital, chairman for the NABH, which is a very big and difficult task, member of the Governing Council of Janakpuri Super Speciality Hospital Society, Delhi, member governing body Sri Venkateshwar Medical College, Pondicherry, member IQAC, BD Sharma University, Rohtak, and the former chairman, Board of Management, Sir Gangaram, and many, many more years. And I just heard that Sir has got 38 years of experience in the field of critical care and medicine. So we are very honored, Sir, to have you in our midst. And may I please invite you on stage. First, I invite the president of Aurobindo and Veritas, Manish Kumar, Sir, to felicitate Dr. B.K. Rao. Upar aa jaiye, sir. And then we would request you, sir, to address us a bit. Before Sir just addresses us, let me just also call on stage the speakers, Dr. Sanjay Kalra, Dr. Surya Kant, Dr. Rahul Pandit, a very, very close friend of mine, He and me have come all the way from Mumbai. And can we ask Mr. Manish to felicitate all of them? I now request Dr. B.K. Rao to please enlighten us and give us a few pearls of wisdom and take this entire conference forward. Thank you, sir.
Thank you for that kind introduction. Good evening, everybody. Like every day, I start my day and I will start this session first by paying tribute to all those frontline workers and healthcare workers who stood up, who fought COVID, and who put themselves in the harm's way. We also pray for those who fell in the line of their duty. So on that somber note, we will start this symposium. You all know, as was said, that this is the biggest tragedy ever faced by the mankind in the last 1 century. And if we go by the WHO figures, then it is not very surprising knowing that every 7th man who walks on this earth is an Indian. And every 10th man who died of COVID was an Indian. That was the scale and the magnitude of the problem that our country had faced, our country which has limited resources, our country which has got a very rickety kind of healthcare systems, even in the best of times. So it is a big tribute to all of us that we could manage to fight it out. We could manage to survive this. The overall incidence of mortality may not be very high, but certain sections of healthcare, practitioners, especially the intensivists, we all know that we fought and we had a very harrowing time because the mortality rates were very high. But I will give credit to Aurobindo and to Veritas and to everybody else who still thinks that the jury is still out. The evidence is still pouring in. We still do not know everything. The last word about COVID has not been said. And with that spirit, we assemble, we learn from each other, we discuss things. We want to learn both from our national as well as international people. And that's the only way we can fight out this pandemic and now an endemic. And hopefully, we will see a bright future in times to come. Thank you very much for inviting me. I hope you will have a great time listening to our experts here.
Thank you, sir. Thank you, sir, so much for always guiding us. And nothing can be begun without paying homage to God and seeking blessings. And therefore, I would request, sir, the dignitaries on the dais to do a lamp lighting ceremony, please. Can I have the slideshow, please? Yeah. So friends, before we move ahead with all the speakers, which you all are all very, very happy and eagerly waiting to listen to, let me just tell you that COVID has been a menace, a demon, an unknown enemy to begin with. It's caused mayhem worldwide. It's led to loss, grief, and depression. It's led to economic and social crisis, exposed the inadequacies of our pre-existing healthcare systems, not only in India, but worldwide. And we've realized more and more that what does not work rather than what works. I can't get onto the slideshow. So in the last 20 months, I have just jointly put 20 points that we have learned from COVID. One is right from the testing, from RT-PCRs to rats to feludas to gene experts, and then the point of care testing, the cycling thresholds and its controversial correlation with the severity, the HRCTs, the biomarkers, the PPEs, the N95s, and then the COVID appropriate behavior, droplets to evidence on airborne disease from the COVID, tracing containments, micro-containments and quarantine, clinical scenarios like SARI and varied presentations like gastroenteritis, and also in the select high group of patients like asthma, COPD, obesity, diabetes. And we have Dr. Surya Kant on telling us about severe asthma in COVID. Treatment based on the mild, moderate, severe critical care groups, no positive effects of the hydroxychloroquine and the ivermectin. Remdesivir as a controversial magic drug and its shortage, antibiotic, and then steroid stewardship, which Dr. Sanjay Kalra will enlighten us on. Development of mucor, its misnomer as a black fungus, attributed also to the under-monitored and the overuse of steroids. Oxygen audits and the need for oxygen therapy and its saving lives, and some lives lost because of its shortage, which was mentioned. And none other than Dr. Rahul Pandit is going to discuss oxygen therapy in the ICU in depth. Cheapest and assured benefits of proning. And I will end here with my last slide, where mechanical ventilation and ICU management will be discussed by our international speaker, Dr. Neil McIntyre. Variants and its effects on transmissibility, severity, and immune escape, vaccinations, waves, and then the science of lockdown and the art of unlocking. And I would then have a talk on the medico-legal aspects by by Ms. Gupta. So I end here and I introduce our next speaker, and that is Dr. Neil McIntyre. He is the MD Clinical Chief, Pulmonary Critical Care Division, Medical Director, Respiratory Care Services, Professor of Medicine, Duke University, Durham, North Carolina. And he's been a principal investigator and a co-principal investigator for 37 clinical trials across the world. He's been a consultant to several clinical research organizations, to name a few: ACCP, SCCM, AARC, and many more reputed world over organizations. He's been a medical director, and as in that post, he's done justice by ensuring evidence-based practice in the Duke's critical care unit. So can we have his talk, please?
Thank you very much for that kind introduction.
Only and
It's
only
my
when the
pleasure
ventilatory
to-
management and the ICU care, the fast hug BID is carried out well, would the results be very good, and not all the drugs that we have.
Are we ready to go? Am I coming through to the meeting?
Sir, you can start, please.
Oh, good. Thank you. I was not sure I was connected. Again, thank you for inviting me to this important meeting. I'm going to spend 20 minutes giving you my thoughts on the current status of COVID and COVID management. I'm going to talk briefly about the impact management of the respiratory infection COVID. Next slide, please. And next slide. So these data are well known to all of you in India and around the world. It is a global pandemic. It has killed almost 5 million people. My country, US, and your country have been particularly hard hit. As you just heard, we are learning how to manage it much better. Next slide. So I want to talk about the respiratory infection. And my first question is going to be, is COVID respiratory infection? Yes. Next slide. So ARDS is not a specific disease, it's a syndrome. And the Berlin definition is it's an acute process. It affects both lungs. It creates hypoxemia, and it is not entirely explained by chronic congestive heart failure. ARDS, as I say, is a syndrome. It has multiple etiologies. It has a broad range of severity. It has different types of pathology. It has different types of trajectory and biomarker profiles. Next slide. So I would like to argue that COVID respiratory failure meets these criteria for ARDS. It is acute, it is bilateral, it is hypoxemic, and it is not congestive heart failure. The etiology is an infection. The severity can be mild, moderate, and severe as graded by the P to F ratio. The pathology is neutrophil exudates that evolve into diffuse alveolar damage and fibrosis. And I would make a comment here that COVID ARDS does seem to last or does have a prominent vascular component to it as well. The trajectory, it can go from days to many weeks, and indeed many patients with COVID respiratory infection can have a very prolonged course, including a very prolonged chronic recovery phase. And the biomarker profiles, there are patterns of both hypo and hyperinflammatory profiles. So COVID meets all the criteria for ARDS, and I think we should think of it as a type of ARDS. Next slide. So let's talk about ventilator management, because that's one of my favorite topics. Let's go, next slide. So the cornerstones of managing ARDS on a ventilator are fairly straightforward. We want to support life. PO2 targets of 55 to 80 millimeters of mercury, pHs in the 7.3 to 7.45 range, although I must emphasize that we can allow permissive hypercapnia to protect the lung as long as hemodynamics of the patient will allow us to do that. We also need to protect the lung. We need to aim at limiting injury, especially in healthier lung regions, and these are typical of all forms of ARDS, including COVID-19 ARDS. The basic rules of managing these patients is we want to limit maximal distension to the physiologic maximum, and that means a plateau pressure less than 30 centimeters of water. We want to limit tidal distension to the physiologic range. By that, I mean tidal volumes of 4 to 8 mLs per kilogram of ideal body weight. And we want to use balanced PEEP and FiO2 to oxygenate the patient while minimizing overdistension and exposure to FiO2. And I have found over the years that the tables that were generated by the ARDS network that are easily accessed on your iPhone by just Googling PEEP-FiO2 tables, these have been very useful in managing ARDS of all types, including COVID. There are two variations of these tables. One is a high PEEP table that is used for sicker patients, and one is a table that uses lower levels of PEEP for patients with better compliance and better P to F ratios. And I really want to emphasize right here that the ARDSNet-based lung protective strategies I've just outlined have an extremely strong evidence base. And we have learned that during the COVID pandemic, using these rules, these strategies have translated into what I think are the best possible ventilator outcomes. Next slide. These are the data from the original ARDS network study emphasizing how useful these strategies are. These are mortality and patients alive and off the ventilator over 180 days following randomization to a protective strategy, the solid upper lines, and versus more conventional strategies which used higher pressures and volumes in the past. The world has adopted these strategies for ARDS, and I really want to emphasize, I think they should be adopted for COVID as well. Next slide. There's been controversy here, however. Two very famous physiologists, clinicians, John Marini and Luciano Gattinoni, have argued that the COVID ARDS pattern has a lot of dead space and often has a lower biomarker inflammatory pattern. And because of that, they've suggested that maybe we could use higher tidal volumes and lower PEEP. Unfortunately, they don't offer any real clinical data to support these strategies, but argue from a physiologic rationale. I know John Marini and Luciano Gattinoni very well. They're friends, and I really respect them. But I'm afraid at the moment, the clinical evidence base, to me, suggests that we should be sticking with what we know works well in ARDS, standard lung protective strategies. Next slide. And one of the reasons I say that is because these data are from the original ARDS network study back in 2000. And what I want you to look at is that the healthiest members of this study population, the ones with the best compliance and the lowest inflammatory state, the ones on the far left, even they benefited from a lower tidal volume lung protective strategy. So just because we have a lower inflammatory pattern and just because the patients don't look or may not have quite the abnormal physiology and stiff lungs that more or other forms of ARDS may have, what I want to emphasize is that this lung protective strategy that's been around for 20 years works for the healthier patients and it works for the sicker patients. And again, should be used, in my opinion, for all those with COVID ARDS. Next slide. I think this is summarized nicely in an editorial from Todd Rice that was published a little over a year ago, where he was arguing that social media and other authorities in the field were arguing that we needed novel, not evidence-based management strategies with larger tidal volumes, airway pressure release ventilations, long inspiratory time strategies, the volume diffusic respirator. And Todd wanted to emphasize, just like I'm trying to emphasize, that calling for paradigm shifts is really unfounded. And he has a classic quote here that I'll summarize: abandonment of evidence-based principles is clearly unacceptable at this time. And I think Dr. Rice is exactly right. Next slide. So ventilator management, again, is straightforward. In my opinion, we follow the standard lung protective strategies that we've been using successfully for the last 20 years. The one additional comment I'd make, I don't have a slide on this, is that another parameter we've been looking at very carefully to help us in lung protection is a parameter called the driving pressure, the plateau pressure minus the PEEP. And in addition to keeping the tidal volume, plateau pressure, and PEEP evidence-based, I think there's growing evidence that keeping this driving pressure less than 15 may also help. There's more to managing COVID than ventilators. Pharmacologic management. I know you're going to hear other talks on this during this symposium, so I will be very brief here and review the three basic medical approaches we use in the United States, approaches that have been approved by the United States Food and Drug Administration. Next slide. The first of these is the use of monoclonal antibodies early in ambulatory COVID. There are several studies, a couple of them summarized here, that emphasize that giving monoclonal antibodies to early, not so very sick ambulatory COVID patients can actually reduce progression of disease. And that's one of the medications we use in the United States approved by our Food and Drug Administration. Next slide. The other drug that I know you all are familiar with is remdesivir. This is also approved in the United States. It has been well studied in large studies, the biggest one published last year in the New England Journal of Medicine. Next slide. And the data here, I think, are pretty convincing. The overall study summarized in the upper left panel shows that remdesivir proportion recovered was significantly better. And what's interesting is the circled graph on the lower left, which emphasized that this was particularly important in patients who were sick enough to require oxygen. If they were not sick enough to require oxygen, this drug did not seem to help as much. Next slide. And dexamethasone. This is a potent corticosteroid with predominant glucocorticoid activity, and this too was studied very extensively. The largest study, again, published in the New England Journal of Medicine in 2020 with 11,000 patients. Next slide. And again, I want to emphasize the overall effect looked good. This is mortality being plotted over time. But I want to emphasize, again, the circled graphic in the upper right to illustrate that, in fact, it had its most prominent effect in patients who went on to require mechanical ventilation. So the bottom line, dexamethasone reduces mortality in hospitalized patients requiring mechanical ventilation. Next slide. Although this is not specific to COVID, I would like to point out a fourth medication that we use, that is anticoagulation. I mentioned earlier, there does seem to be a predominant vascular involvement in COVID ARDS. And we learned some time ago that anticoagulating people with COVID did improve outcomes. It lowered the admissions with respiratory failure, as illustrated on the right. Fortunately, bleeding complications were very low. There was a controversy right from the start, however, about whether this should be full dose anticoagulation or more traditional so-called prophylactic anticoagulation. Next slide. And this study just came out recently. Intermediate versus standard dosing of enoxaparin. Next slide. And I think the results speak for themselves. There really wasn't much benefit here in terms of higher dose enoxaparin in these patients with COVID respiratory failure. So the bottom line here is that intermediate anticoagulation is adequate for most patients with COVID respiratory failure. Next slide. So let me spend a couple of minutes on some of the other support strategies that we use in the ICU, along with our ventilators and our medications. Next slide. I want to touch on 4 briefly: the high flow nasal cannula, the prone positioning, the use of neuromuscular blockade, and finally, ECMO. Next slide. The high flow nasal cannula has been a particularly useful modality. It's different from a traditional nasal oxygen in that the flows can be very, very high, 60, and some newer devices actually go up to 80 liters a minute. And it does 2 very important things besides just supply oxygen. Number one, it creates a washout of all the upper airway dead space, the nasal pharynx, and makes ventilation more efficient. And the second thing it does is it gives a small amount of CPAP on the order of 3 to 7 centimeters of water. Next slide. This is an older study in other forms of ARDS that illustrates that using the high flow nasal cannula instead of standard oxygen or non-invasive ventilation actually had a mortality benefit. This is other forms of ARDS. Next slide. And patients who were particularly hypoxemic, this really had a dramatic effect on lowering the need for intubation. And that's why it probably improved ultimate outcomes. It kept patients off the ventilators, complications of ventilators, and improved outcomes as a consequence. High flow nasal cannula is a mainstay of therapy at my institution. Next slide. And more recently, HFNC, high flow nasal cannula, has been studied in COVID. And I've outlined the important outcomes here, showing that the need for mechanical ventilation and mortality are improved by the use of the high flow nasal cannula to avoid intubations. Next slide. In fact, it's now a standard recommendation by a number of authoritative bodies. High flow nasal cannula is recommended, suggested, and this is a superior device to use over non-invasive ventilation. In fact, in my institution, if you fail high flow nasal cannula, if you're not doing well with the high flow nasal cannula, you do not go to non-invasive ventilation, you go on to intubation. And one of the scores we've been very interested in is called the ROC score, which is basically the P to F ratio over the FiO2, or excuse me, over the respiratory rate. And there are tables that you can Google that give you an idea of the probability of the need for intubation. And we couple that ROX index with high flow nasal cannula as a way of trying to avoid intubations, and then using intubations when they really are needed. Don't delay intubation when it's needed. Next slide. Prone positioning. This has become a standard of care. Next slide. Prone positioning has very sound physiology. You get much more air-rated lung. The heart is now not resting on the left lower lobe. Gas exchange is better. And in ARDS, going to the prone position in patients with low P to F ratios, next slide, does improve outcomes, including mortality. This is the study published in the New England Journal several years ago. What's important is that this same effect is being seen in COVID ARDS. Next slide. Prone positioning has become a standard of care. You can even do it in non-intubated patients. This is being tried more and more as a way of trying to improve oxygenation and hopefully avoiding intubation. Some people respond very, very nicely to this, and these are non-intubated patients, and we are using this in an increasing fashion in my own institution. Next slide. Neuromuscular blockade is controversial. It's a two-edged sword. Next slide. This is an older study suggesting that the use of early neuromuscular blockade in severe ARDS actually improves outcome. Subsequent studies have not been able to see such a dramatic effect. Nevertheless, it does have clinical benefits, and I think is worthwhile using in early ARDS to get patients on the who have just been intubated on the ventilator. Next slide. It does reduce oxygen consumption, it improves dyssynchrony, and it limits tidal volumes. The downside is disuse atrophy, which can increase and accentuate critical care myopathy and post-ICU weakness. Next slide. In practice, as I say, with conflicting clinical trials, my own advice is to use it early until the patient is more stable. Again, you may not total paralysis, or muscular blockade, I should say, to reduce oxygen consumption and ventilator dyssynchrony. Next slide. And finally, I want to touch on extracorporeal membrane oxygenation. Next slide. This is a technology that is not widely available, but it's a very simple form of extracorporeal membrane oxygenation, veno-venous, where you take a catheter and drain as much as 70% of the cardiac output from the venous system into a membrane oxygenator and return it to the right atrium and right ventricle for delivery into the lungs, where the lungs can add to the oxygenation. It is really good at getting CO2 removal accomplished. Oxygenation is not 100%. The lungs still need to contribute to the oxygenation process. A problem with it that is still or still can be challenging is the need for anticoagulation. Next slide. This is to show you that in traditional or other forms of ARDS, severe ARDS, there is a trend for mortality benefit in using ECMO. If you look at hypoxia, this difference becomes more significant. Next slide. We use ECMO at Duke in the patients who are failing conventional ventilation with standard lung protective strategies and who do not have more than one organ failure. Next slide, please. So in other words, if you have multi-organ failure, ECMO is not offered to patients. I need to go on to my final couple of slides here, please. Yeah, there we go. That's just showing you, if you look at different ways of looking at these data, the ECMO group does reach statistical significance. Next slide, please. So I want to conclude by just looking briefly at outcomes. Next slide. This is a very nice review in Critical Care Medicine, just published a few months ago, showing the effects of age and showing the effects of the need for mechanical ventilation, the need for mechanical ventilation and vasopressors, the need for all three, and the use of ECMO on mortality. As you can see, age does have an effect, and not surprisingly, the more organ failures you have, and the more needs for invasive support therapies, the more your mortality is increased. Next slide. So let me summarize and conclude. Not something you all know already. COVID is a huge global issue, almost 5 million dead so far. It is ARDS. Ventilator management should use standard lung protective strategies. In the US, we have approved medications that are standard of therapy now. Other support strategies that I think have roles are the nasal high flow cannula, prone positioning, neuromuscular blockade, and if you have an ECMO center, for those patients who do not have multi-organ failure, but who are failing lung protective strategies, are candidates. And again, not surprisingly, outcomes are related to severity, age, and other organ failures. I've come to the end of my formal comments here. I will turn it back over to the moderator. And again, thank you so much for this opportunity to address my colleagues in India. Thank you so much.
Yeah. Thank you, Dr. Neil McIntyre, for giving us an extremely livid talk and in-depth it's echoing. An in-depth definition of what should be done and what should not be. You've not only laid down the evidence that works, but you also have told us the controversies. And we all know that COVID and ARDS is a very heterogeneous disease. We also know that almost 50% of the patients with COVID ARDS also have thrombosis. And we also know that they can have secondary infections, bacterial and fungal, making it much more difficult. So thank you for this very, very livid and extremely exhaustive talk on mechanical ventilation. Thank you, Dr. Neil, once again. Can we have the echoing? We now move on to the highlight of today's event, and our chief guest, Dr. Randeep Guleria, is going to join us and address us very shortly. For those who have joined in late, it gives me privilege to again introduce Dr. Randeep Guleria to you, whom all of you all know. He is the Padma Shri and the BC Roy awardee. He is the director of the most reputed hospital, that is AIIMS, New Delhi. He's an expert in many national and international organizations and forums like the CDC, WHO, and the IAEA. He has over 400 publications and written 15 chapters in international and national textbooks. He's been a key member in many Government of India organizations, and he's dedicated his life in teaching the medical fraternity for over 30 years. I've had the privilege of being a co-panelist along with Dr. Guleria a couple of times, and I know he's a very erudite speaker. He always leads from the front and he brings the benchmark to the bedside. And I again request Dr. Guleria to enlighten us and what is the way forward. So over to you, Dr. Guleria.
Thank you very much. I hope you can hear me, and thank you for inviting me. I hope I'm audible. Yes, sir. So at the onset, let me really thank the organizers for inviting me, especially Nilesh, and really congratulate everyone for Aurocon. I'd like to really apologize for not being present there physically, but today we have our foundation day, the institute day, on the 25th of September, and we have our Golden Jubilee oration in the morning. We had an exhibition with posters from the faculty and the residents, which was on digital health and medicine, which was inaugurated by the Honorable Health Minister and the Minister of State for Health. And many other functions were there. And in the evening, we have our culture program, and therefore I could not come physically because the culture program has just finished in our auditorium. But let me really take this opportunity to thank the organizers for inviting me, and I'm very happy to be here virtually. I see that you have a real star of speakers lined up today, and it's really a pleasure to know that almost all of them are present physically. So we seem to be gradually moving towards the pre-COVID era of having our conferences and meeting physically, where we can really interact with our colleagues and be able to socially meet, and many of us miss those times. I'm just briefly going to touch upon the COVID management, because this is what this conference is all about, and there has been a lot of learning in the last 18 months. I remember when we started off in February, March in the management of COVID, and we had meetings in our own department, in our own institute, and also in ICMR when the National Task Force was still being formed. The treatment strategy revolved around anti-HIV drugs, lopinavir, ritonavir, and that was data coming out of China. And then there was data coming on hydroxychloroquine, especially data which suggests that it may be useful. And at that point in time, we were grappling that this is a new virus. We really don't know much about it. There was suggestion that we should even try oseltamivir, which is Tamiflu for H1N1. And I think we have come a long way since then in knowing more about the disease. It's not just a simple pneumonia. It causes significant systemic effects. It causes endothelitis, which leads to hypercoagulable state. It also causes a cytokine release syndrome, which leads to self-destruct phenomena and we need to treat that. And we also realized that the treatment that we were giving in the beginning of the pandemic was probably not right. We moved on to really picking up treatment strategies. The recovery trial showed the usefulness of steroids. Having said that, there were people who had already started using steroids, but the evidence was not there. The recovery trial gave a very strong evidence, but it also showed that steroids are useful only when they are used in the proper stage. That is, when you have moderate illness or severe illness, and those who have mild illness and don't have hypoxemia, steroids can do more harm than good. And this really clearly came out in the trial, although there was a lot of misuse of steroids, especially during the second wave. A lot of controversy also with another repurposed drug, that was remdesivir. The initial trial which came out from China actually showed it was of no benefit. The study actually had been stopped early because of the fact that the pandemic had decreased in China and they were not able to recruit the sample size that they had needed. But that study did not show a benefit. Subsequent study did tend to show that it decreases hospitalization by a few days, did tend to show a direction towards mortality benefit, but it did not reach statistical significance. So remdesivir also became a drug to be used in moderate to severe cases, but the data was not that strong. But then there was a huge demand, and I remember again, more than a year ago, there was huge shortage of remdesivir. There was literally a black market, and we were getting remdesivir, which was coming from the company, but it was also coming as a product from Bangladesh, where it was being made as an unpatented drug and crossing the border. So those were times where remdesivir became a really go-to drug, despite the data not being that strong. As we realized that there were patients coming with stroke, with pulmonary thromboembolism, treatment with anticoagulants started, and there was a lot of aggressive treatment with anticoagulants. There was a lot of controversy, which was also discussed by Dr. Neil McIntyre, as to what should be the dose of the anticoagulant. Should it be prophylactic dose? Should it be therapeutic dose? We started off with prophylactic dose in mild to moderate cases who were admitted, but then most clinicians moved on to a therapeutic dose in those who were being treated with severe illness, because they felt that even with the prophylactic dose, they were seeing thromboembolic phenomena. However, again, the data which was published in various trials, including the data from JAMA, did not show any additional benefit of therapeutic dose of anticoagulants as compared to the prophylactic dose. There was also an in-between dose which was used, which was a semi-therapeutic or a low-dose therapeutic dose, which was also tried. It also led to another controversy as to should we continue anticoagulants after discharge, especially looking at the DOACs, the direct oral anticoagulants. Will they be useful in some patients because of the chance of coagulation happening later on, especially in that subgroup who had high D dimer or had high features to suggest a thromboembolic phenomena? Again, still no real definite data on it, but this is again something which many physicians do, that they would continue oral anticoagulants for a longer period of time. Then we had the controversy of the anti-IL-6 drugs. What should be done for cytokine storm? It started off with people giving pulse steroids. They didn't seem to work, and then anti-IL-6 drug tocilizumab became the drug of choice. I had at that time, at one point in time, gone to Gujarat really to see the COVID management strategy there, and I was told that there are people waiting in line for more than a day outside chemist shops to get one vial of tocilizumab. It became that important a drug at that point in time. Again, the data was not very strong, but it was something that was used extensively. Subsequently, meta-analysis and data did emerge, although you could go one way or the other, but there is now data which suggests that in a select group of patients, anti-IL-6 drugs like tocilizumab may be useful, and I think that is gradually becoming more and more the treatment strategy. But in India, we had other drugs which are used. Favipiravir is one, ivermectin is another. The data, again, not that strong, only observational study, no good randomized controlled trial. But these drugs were used extensively for mild cases and at times even for moderate cases without that much of real evidence. And I think still these drugs are being used as part of treatment strategy. As we did a lot of EICUs, I've interacted with more than 500 hospitals across the country. I realized that there was a lot of lack of awareness as to what should be the management of COVID-19. There were centers which were giving methylene blue, treatment and swearing by the fact that if they give methylene blue to their patients, they recovered better as compared to standard of care. And there's really no data to support the use of methylene blue. Similarly, there were centers which were giving high dose steroids, pulse steroids, in all cases of mild and moderate disease, with the theory that this would help. I remember arguing with one physician who said that in all his patients who turn out to be COVID positive on day one, he's giving remdesivir, irrespective of whether they are symptomatic, asymptomatic, or are maintaining their oxygen saturation. His argument was that if I am able to decrease viral replication early, then this patient will improve, and therefore there is a need to give all patients remdesivir early. So I realized that there is a lot of discordance in terms of treatment, and we really don't have standard of care because the evidence was not there. We were not able to show the evidence in a proper manner, and there was a lot of panic among individuals, which led to a lot of conditions of mistreatment. We also then had conscious proning. Initially, there was a lot of debate and worry among our healthcare workers to give non-invasive ventilation or high-flow nasal cannula because of aerosol generation and the fear that that could cause infection. Gradually, that confidence came, and I think we saved many lives by giving high-flow nasal cannula and non-invasive ventilation. We became very good at it, as we did in terms of conscious proning, and many patients with just good oxygenation came out of COVID-19 without having to be intubated and put on a mechanical ventilator. But I think what the basic lesson that COVID-19 showed us was the basic principle of medicine: do no harm. And I think that was very, very important. And the other importance was that these drugs have to be given at the right time for the right patient. If we give steroids too early, they will be more harmful. Similarly, if we give remdesivir early, it may not be of any use. If we give anti-IL-6 drugs, in mild cases, they can cause more harm, lead to opportunistic infection, and therefore only in a subgroup of patients should we really look at giving tocilizumab when we are sure that this patient is going on for cytokine storm. And that is now the strategy, that giving the right drug at the right time is very, very important if you want to manage COVID-19. Now we have monoclonal antibodies also, which have entered the market. They're available in our country. And I think they, in many ways, could also be a game changer, because in the select group of patients who have a high risk of going on to severe disease or who are elderly, monoclonal antibodies given early can also be helpful. Therefore, we are learning more and more as far as the management of COVID is concerned. The virus is also evolving. It is still teaching us, and therefore we should be vigilant, but be careful that we don't do harm to our patients and work on a strategy that we are able to protect and save as many of our patients as possible. So this is the brief overview that I wanted to give. Thank you for a patient hearing, and thank you for inviting me. Thank you very much.
Thank you, Dr. Guleria, once again for giving us a complete gist of our journey through the COVID management, telling us what works, what does not work, and bringing a very, very important point out, that is that primum non nocere, do no harm, and just do symptomatic treatment, follow the ICU principles, give them oxygen, give the right drug at the right time, and carry out your basics in the management of a COVID patient. So thank you once again, Dr. Guleria, and keep enlightening us and blessing us in our journey in fighting COVID in India and across the world. I now move on with the conference, and it is a pleasure to invite Dr. Sanjay Kalra, who is now going to talk about steroid stewardship. Dr. Sanjay is the Vice President of the SAFES, that is the South Asian Federation of Endocrine Society. He's an MD, DM in endocrinology and practicing since 2000. He's been an executive editor of the Indian Journal of Endocrinology and Metabolism and the editor-in-chief of the International Journal of Clinical Cases and Investigations. His outstanding research background has earned him several national clinical awards. In as regards steroids, we know that the recovery trial, the solidarity trial, they all told us that if we did use steroids at the right time, they would be useful. Along the journey, we got a little setback by increased number of mucor cases, and then we had controversies whether it's only dexamethasone or all the steroids are the same or are they different. And I look forward to a lovely presentation on steroid stewardship by Dr. Sanjay. Welcome.
Good evening, everybody. It's a great pleasure being with everyone today. COVID has come. It has not yet gone. COVID is still there. But there are many lasting effects of COVID that will remain with us. Many, you'll have to help me. Many memories, some pleasant, actually pleasant because we learned new things, many bitter. But one of the good things that COVID did was that it was a wake-up call for our profession. We realized that we have to be more responsible towards not only clinical practice, but also towards public health. Let's go into endocrinology and let's talk about something that happened 70 years ago. 70 years was awarded to Kendall and Reichstein and Showalter for the discovery of hormones of the adrenal cortex. A tiny gland, the adrenal gland. Each gland weighs how much? We have MD medicine students from AIIMS. How much does an adrenal gland weigh? 3 kg? Nah, 300 grams? Yeah, okay, that's yes from AIIMS New Delhi, 300 grams. Thank God Dr. Guleria is not listening to us now. Any other idea? Only 3 grams. Each adrenal gland weighs only 3 grams. The heart weighs 250 grams, but you can live after a myocardial infarction. The spleen weighs 200 grams. You can live 100 years after splenectomy. Each kidney is 150 grams. A nephrectomy does nothing to you. I mean, you can go and donate a kidney if you want today. But can anybody live without these 3 grams of adrenal tissue? Again, AIIMS New Delhi, yes or no? Can anybody live without 3 grams of adrenal tissue? Yes or no? No. Oh, shabash. We need to clap. So the adrenal gland is important. We need to take care of it. How do you take care of, let us say, antibiotics? You call it antibiotic stewardship. Similarly, let's talk about the concept of steroid stewardship or adrenal stewardship. And let's define steroid stewardship. Steroid stewardship is a systematic effort. So let's be systematic. It's an effort to prescribe and monitor steroid therapy. So not only the prescription, but also the follow-up. How do you do it? You do it in a rational manner, following common sense. Where does the common sense come from? It comes from what you studied in first prof, biochemistry, physiology, anatomy. It also comes from what you study in second prof, pharmacology, pathology, microbiology. Just follow those rules, and then you will never forget that the adrenal gland weighs only 3 grams, right? Yes. And then you help patients. So patients who require this therapy should be given steroids, but that should be done in a rational manner while balancing benefit and potential risk. And that is what Dr. Guleria was speaking to us about. You have to balance benefit and risk. Steroid stewardship is not limited just to prescribing a drug and then following it up. Stewardship will begin before the prescription, it will continue during the prescription, and it will last even after the prescription. That is why we have chosen this topic for today. COVID may have come, the waves may have gone, but our responsibility for steroid stewardship will continue. Pre-prescription. Whenever you, as a physician, want to prescribe steroids, you should know what you are doing. There should be clarity in your mind about why you are prescribing a particular corticosteroid. Once that clarity is there, then you go and counsel your patient. we tend to think of steroid stewardship as being limited to the ICU or being limited to the COVID care setup, but it is part and parcel of every aspect of medical care, in the OPD, in the ward, in the ICU, everywhere we use steroids. But you should know why you are using them in a particular situation. Before you begin steroid therapy, do a proper screening. The screening can be based upon history taking. It should include examination, and you will need a few investigations. Once you've done that, you move on to prescription. When you prescribe, you have to ensure that you're choosing the right type of steroid, the correct dose, the mode of administration. Will a topical steroid help more than oral, or will intravenous help more than oral? Do you want to give intravenous infusion, or do you want to give a depot preparation, maybe intramuscular? How long do you plan to prescribe the steroid? What is going to happen during this prescription? What will you monitor? How will you change the dose? How will you titrate? What will you follow up for? What kind of history will you take? What kind of biochemistry will you ask for? If a sick day occurs, I am on long-term steroid therapy, I develop a fever. What should I do? Should I increase the dose of steroids? Should I keep it the same, or should I stop? If I have nausea and vomiting, I'm afraid that I will not be able to eat properly. What does that mean? Should I take more steroids, or should I stop them? All these questions should be answered in your mind and should be informed to the patient as well, if your patient is going to be on long-term steroid therapy. And then a time has to come when you want to taper or you want to wean off. That should be planned well in advance. This is during therapy. Let's say you've weaned off your patient, you've stopped steroids. Will steroid stewardship finish then? The answer is, we're getting better at it. So whenever I ask a question, the answer to which is no, then Shubham Sani answers correctly. So now I have to think of an answer. I have to think of a question to which the answer is yes. So this is going to be a googly question. Okay. After steroid therapy, there may be adverse medical events or adverse endocrine abnormalities. Yes. So that is why we have to continue steroid stewardship even after prescription. And we have to, if there is a side effect, we have to mitigate it. It's nice having young boys and girls in the audience. It keeps you young, especially when the boys are handsome and naughty. So just a few things which help me in my practice. Everything should be in black and white. And black means that whenever you are prescribing a long-term therapy to anyone, whether it is corticosteroids or insulin, or even an NSAID, or even maybe a cardiotropic drug, a psychotropic drug, everything should be written in black and white. What are the expected benefits? What are the limitations of the therapy? If I am giving you steroid therapy, is it going to make you happening, let's say being a 70-year-old gentleman, is it going to make you a 25-year-old boy again? The answer is no, obviously. But that has to be told. There has to be a reality check. If the patient expects that for rheumatoid arthritis, she is going to get steroid therapy and then she is going to go and climb Mount Everest, that is not going to happen. So the reality check should be there. What are the possible adverse events? So black is B for benefits, L for limitation, A for adversity. What is the cost? Cost of therapy, C. And K is, do you need any knowledge or skills to take that drug? A knowledge may be just that do not take this drug empty stomach, take it after a meal. A skill may be you have to inject yourself subcutaneously. So this is how to take an injection subcutaneously. So everything should be in black and white. Even before going into black and white, be aware of the 4 C's. It is very easy to prescribe a drug. It is very easy to suggest go and get a Whipple surgery done or go and get a cesarean done. But the good doctor is the one who knows the contraindications. So what are the contraindications? What are the concerns and caveats while prescribing? And are any checkpoints required? Do I need to do a blood pressure every day? Do I need to do a glucose every week? Do I need to go and do a GTT? These checkpoints should be mentioned, should be explained to the patient. And also when you prescribe, especially if you are following up the patient for a long period of time, and especially if there are multiple people in the healthcare team, D for document everything. Because there are multiple people contributing to the patient's health. Talk about the dosage at initiation, the planned duration of action, or treatment, the planned dosage titration, is there a need for a dose holiday or not, and if sick day occurs, what do we do? So these are simple things that we should all follow, whether you're doing an asthma OPD or whether you're doing ICU management or you're maybe working in rheumatology. We should also know that we are all from different specialties, and that is why we have different opinions about steroids. We all view corticosteroids through blinkered eyes. I am aware of 3 overarching indications for steroid therapy. And now a tough question. Yeah, why do some boys at the back smile whenever I utter the word question? So these are 3 indications that I am aware of. Is there any other indication? For glucocorticoid therapy, the indication will be either you are replacing steroids in a patient with primary or secondary adrenal insufficiency, or you are using it for anti-inflammatory effect, or in certain critical care situations, you are giving it as a vasopressor. You are giving it for hemodynamic stability for a short period of time. Is there any other indication? Yes, okay. And you have to speak out loud. Hematological malignancy, okay. But is it not for the anti-inflammatory effect of some other drug that is being given for the malignancy? It would come there. There is another indication, though it is very, very much off-label, and that is for the treatment of hypoglycemia. You have a patient with hypoglycemia. The patient is just not recovering. You've tried everything. You've given as much dextrose as you can, and the patient is not recovering. Just give a shot of hydrocortisone and see what happens. So this is a backup for hypoglycemia management. Whenever you have decided to give steroids, you should be aware of why you are doing it, so you know your indication. Be respectful of people in other specialties. In different specialties, people use the same steroid for different indications. So be aware that their approach is different. They will be having different prescribing instructions, and the drugs that they use will have a different potency. If I want to use steroids for rheumatoid arthritis, for anti-inflammatory effect, I'll use a different drug. If I want to use it for adrenal insufficiency, then I will use hydrocortisone only. If I want to use a steroid for a short period of time, I will use high potency, I will hit early, hit hard, and then I will back off. But if I want to give a steroid for a long period of time, I would choose a steroid of lower potency, give it for a long period of time in a low dosage with low potency. So my approach will change. If I want only anti-inflammatory effect, then maybe I will choose prednisolone, methylprednisolone. But if I also want salt retention, I want a mineralocorticoid effect, then maybe I will want fludrocortisone. I can choose both together also in adrenal insufficiency. So we should be aware of these nuances, and we should choose our drugs accordingly. There is a long list of assessment, but you should be aware of the common metabolic disorders and at least look for blood pressure, dysglycemia, weight gain, skin disease, mood disturbance. Ask about these questions before starting steroids. Some medical conditions that can be worsened by steroid therapy will include weight gain, osteoporosis and sarcopenia, dysglycemia, mood disorders. Steroid therapy is one common cause of hypomania. Diabetes is something that concerns all of us, and this was brought into stark focus during the COVID-19 pandemic, during the second wave. We had so many patients with aggravated hyperglycemia. Undiagnosed diabetes was unmasked, and corticosteroid diabetes became rampant in all our practices. How do you manage? We have very good national guidelines. Dr. Guleria has contributed to them. AIIMS Delhi has led from the front in creating these guidelines, and we should follow them. The guidelines are based upon good clinical sense. They're based upon common sense. When you want to stop steroids, then you have to be careful, because if you stop suddenly, what is going to happen is that adrenal failure may get unmasked, and also the hypothalamo-pituitary adrenal axis takes time to come back to normal. So if you've used drugs for a long period of time, then you have to taper off slowly. Now let us look at the definitions and the rules for this. If you have been giving more than 7.5 milligram of prednisolone, for more than 3 weeks, then you have to taper off. But if you've been using 7.5 or less of prednisolone equivalent for less than 20 days, less than 3 weeks, then you can stop suddenly. So I had COVID-19. I was put on steroids by my physician, by my pulmonologist, and he tapered off. But actually, there was no need to taper off because I had not used them for such a long period of time. So do keep that in mind. And if you're worried about adrenal insufficiency, then you test for that, right? And how can you test? You can do it clinically, but you can also do a synaptin stimulation test. Post-steroid also you have to be careful because adverse events can occur later. Just remember that any kind of metabolic disorder can occur after steroids. Metabolic or mood disorder, monetary disorders do occur, and many times over-management causes monetary dysfunction in our patients in India, so be mindful of that as well. And just be careful. Try to minimize, try to mitigate the impact of all this. How do you minimize and mitigate? You follow something called the law of therapeutic parsimony. Now, parsimony is a difficult English word, so how I remember is that the Parsi community has a lot of money. Daksab is from Bombay, so he knows better. So Parsi money, and they're very, you're a Parsi, okay, so they're very good with their money. So Parsi money means you use whatever resources you have effectively and judiciously, and you use them for a long period of time. So use the minimum drugs in the minimum dose required, in the minimum frequency of usage, provided that therapeutic outcomes are not compromised with. Post-steroid, we've already mentioned, you have to mitigate the adverse events. Do consider routine calcium and vitamin D supplementation. Keep on focusing on lifestyle to prevent weight gain. These are simple things that we can do. And remember that if you have patients with adrenal insufficiency, then glucocorticoids alone will not be enough. You will have to supplement with fludrocortisone and many a times with DHEA, dehydroepiandrosterone. What blood test will you do if you want to diagnose DHEA deficiency? Anybody? Let me give you a hint. It's quite similar to DHEA. Now can you answer? S. What is S for?
Sulfate.
Shabash. So if you want to check for DHEA deficiency, you will do DHEA sulfate and then you get it. If you want to check for fludrocortisone deficiency, then what test will you do? Serum? Serum fludrocortisone? No? Okay, it doesn't exist. Okay, just a sodium potassium should suffice actually. And what vital sign will you check for? And what dynamic blood pressure testing? Orthostatic hypotension. That will give you a clue. Steroid stewardship is everybody's responsibility. Not mine, not Daksa's, not Dr. Galeria's. It is everybody. All of us who are here in this hall together across the country. It is our responsibility. And we should work along with each other, alongside each other. Take the help of clinical pharmacologists. Take the help of your pharmacist, your nurse, your hospital administrator. Reach out to the public. Tell the public the advantages, the strengths of using steroids, and also the limitations and disadvantages of using them, and reinforce the fact that if we use these drugs rationally, they will help us. Let's treat these drugs with respect, with the respect that they demand. Let's give them the respect that they should command. Let's follow steroid stewardship, and we will see that if we do a good job of steroid stewardship, India's stewardship will be better. India's stewardship will be better. We will actually become a healthier and a happier nation. Jai Hind.
Thank you, Dr. Sanjay, for telling us everything that we need to know about steroids. We know that steroids have been there for ages and we've been using it, misusing it, abusing it, and without real reason, we might have prescribed it. All of us as physicians might have done it sometime in our career. The resurgence and the reinterest in the steroid molecule has happened in the COVID scenario, and we have learned a little more about the steroids. And thank you so much for that very, very nice talk. I now invite Dr. Surya Kant And if I sit here to read his accolades and all that he has done in his so many years of practice, I think we'll have to wait till breakfast. But I must mention that he's been a gold medalist in MD. He's got FCCP, FRCP from London and Glasgow. He's FACP USA, and there is no alphabet left in this entire gamut. He's done a lot of task force work in TB eradication, and he's an expert in the past president of Indian Chess Society, the College of Chess Physicians India, and it goes on and on. So we invite Dr. Suryakant to talk about severe asthma and its implications in COVID. Thank you.
Thank you. Thank you very much for kind introduction. It's really a great honor and privilege for me to be here. Especially, it's a tribute for Dr. K.K. Agarwal, Dr. late K.K. Agarwal, the great educator from our fraternity. First guy, yeah. Or yes. Because this conference, Aurocon, I'm really congratulating to the Aurobindo team, and it is being organized under the aegis of Heart Care Foundation of India. Actually, Heart Care Foundation of India, he established, Dr. K.K. Agarwal established in 1986. Can you imagine? So how long it was the journey of Dr. K.K. Agarwal with this social work, as a teaching work, academic work, lot of work he has done. So with great salute, and of course, the great salute to 1586 doctors of modern system of medicine who passed away during the fight against COVID-19. So salute to them. And of course, before starting my talk, I think severe asthma they have kept as a topic because normally control asthma is not an additional risk factor for COVID-19. Then what is the risk factor for is there any risk factor related with asthma for the COVID-19? Anybody? Yes, it is the uncontrolled asthma. So that's why probably the topic is severe asthma. Anybody, what is the significance of this day other than this Aurocon is going on and you are sitting in this hall? What is the significance of this date today? Anybody? Yes, World Lung Day. So today is the World Lung Day and most of us are pulmonologists. So I'm taking the privilege of this day because I'm also pulmonologist and most of you are also pulmonologists. And probably in this country because the Aurobindo team has told me that there are now 51 centers in India where the thousands and thousands of doctors are attending this program. So today is of course, World Lung Day, and the theme of today's day is care for your lungs. Because not only this, that Corona is hitting it, but a lot of diseases are hitting it. So lungs, basically the organ of respiration. It provides you 10,000 liters of air in 24 hours and same amount of circulation, blood circulation in 24 hours. And what's the net result of this ventilation and perfusion? The delivery of 350 liters of oxygen, which is being utilized for our daily activity. You see, of course, everybody has to emphasize its specialty, and I have to also. Dr. Kala was talking of adrenaline, 3 gram adrenaline, what is the importance? So we can live without food for 3 weeks. We can live without water for 3 days, but nobody can live without oxygen or air for more than 3 minutes. That is the importance and that is the significance of lungs. So, and that's why probably COVID-19 and so many other viral infection hitting the lungs. Everybody knows what is the asthma. I'm not going into the, of course, the detail of the definition. Everybody knows, but asthma is the most common chronic non-communicable disease affecting over 300 million people globally in 2020, with 37.9 million, almost 38 million in India, and caused about 5 lakhs deaths globally. Now, this is my, you see, slide of asthma for MBBS student. For a forum like GPs, for a forum like Indian Medical Association, but I love this slide. I've kept you for you also. You know, in one slide, what is the pathology of asthma? It is called ABC. A stands for airway hyperresponsiveness, B for bronchoconstriction, and C for chronic inflammation. But what is severe asthma? Severe asthma, the latest definition, GINA 2021. GINA, everybody knows, it is the international body for the Global Initiative for Asthma Management. It defines that asthma that remains uncontrolled despite optimized treatment with high doses of ICS-LABA. ICS is inhaled corticosteroid, LABA is long-acting beta-2 agonist, or that requires high doses of ICS-LABA to prevent it from becoming uncontrolled. What is the prevalence? Roughly 3.7% of people with asthma, they have severe asthma. So it's a significant number. Because in India, we have around 4 crore population as asthma. And if you just do 3.7%, it comes a lot. So severe asthma places a large physical, mental, emotional, social, and economic burden on patient, on society. Now, if you see the profile of the asthma patient on various stages of therapy, we have the 5-step therapy for asthma management as per the GINA guideline. But 24% of the patient who are in the 4th or 5th steps of therapy, they are having severe asthma. And 17% of those who are in step 4 and 5 treatment with poor symptom control, they are labeled as difficult to treat asthma. And roughly 3.7% are those who are having severe asthma. So that is the patient profile on an average of asthma overall. Now, what should be the practical approach for a patient with severe persistent asthma? This is the real challenge. You see, asthma can be managed by very simple medication, even by MBBS doctors, general physician, family physician. But real challenge for pulmonologist and of course pediatrician and those physicians who are interested in pulmonology, that is severe asthma. So the question is, so 5 steps for planning a treatment for asthma. Remember 5. 5 is very important. Now, first step is, if you really want to evaluate a patient of asthma and manage the asthma, the first step is confirm the diagnosis of asthma. I used to say in Hindi, जैसे हर चमकती चीज सोना नहीं होती, वैसे हर फूलती हुई सांस अस्थमा नहीं होती. बजाओ ताली अपने लिए. क्या बात. So I'm really glad the vibrant audience connecting. Of course, इसका मतलब कोई WhatsApp पे नहीं है, सब connected हैं. So dyspnea can be anemia, dyspnea can be tropical pulmonary eosinophilia, dyspnea can be chronic obstructive pulmonary disease, dyspnea can be due to cardiac region, dyspnea can be due to some other regions. So you have to pinpoint the diagnosis of bronchial asthma. Of course, you have to do, if you see for last 1.5 years, you didn't perform a spirometry because COVID does not allow. Any procedure which is, of course, having the chances of transmission does not allow. So you have to develop the clinical sense. In 2021 also, asthma is a clinical diagnosis. So even when if you are taking the help of pulmonary function test, yes, you can do reversibility, variability, or if you are having the facility like in AIIMS Delhi or in Patel Chest Institute, you can do pethacholine challenge. Now, second situation is after confirmation of the diagnosis of asthma, yes, it is asthma. So what are the comorbid conditions? Yes, very important. You cannot label patient as a severe asthma without controlling all comorbid conditions. Patient is having a comorbid condition in the form of, suppose, diabetes, hypertension, heart failure. You have to control, you have to manage. Otherwise you won't be able to manage asthma also. The third step is, after the confirmation of diagnosis, after the controlling of comorbid condition, third step is control of aggravating factors. Suppose you are treating the asthma, you are treating the lungs very well, but you are not taking care of allergic rhinitis, sinusitis. You won't be able to control asthma properly. So all aggravating factors, maybe allergic rhinitis, maybe GERD, gastroesophageal reflux disease, maybe obesity, maybe so many other conditions, which aggravate the asthma. So you have to rule out all aggravating condition, and you have to rule out that all have been, of course, prevented. The fourth step is adequate treatment, optimized treatment, not per your whims, as per the guidelines. We have international guidelines, GINA also, and we have Indian guideline also. We have made from the Indian Chest Society, from the National College of Chest Physician, from the Indian College of Allergy, Asthma, Applied Immunology. Fortunately, I have been president of all three, as our moderator has already mentioned. So we have formulated all the guidelines, all important pulmonary guidelines. So go through the Indian guidelines also. And so optimize the treatment, very important. Last step, it is not your prescription, but it is the adherence and compliance of the prescription which provides the complete relief to the patient. You may be gold medalist, you have written a beautiful prescription, but patient is not compliant of. Patient is not adhering to this treatment. Prescription does not work. It is the delivery of the drug inside the bronchi that will provide relief to the asthma, not your prescription. So you have to check regarding the adherence and compliance of the treatment. Still after the 5 steps exercise, you feel that patient is having symptoms, patient is not in control, yes, now you declare your patient as severe persistent asthma. After this approach, during this approach, you will require certain investigation. I purposely have kept 5 on the left side, 5 on the right side. Anybody, why? Because on left side, the most of the investigations, they are available throughout the India, at least at the district level. So these are the feasible investigation. Whenever you are interpreting any guideline, whenever you are reading any international guideline, first question ask to yourself, whether this guideline are applicable, feasible to our Indian population. Because you see every district, every block, every village is not AIIMS Delhi. It is not PGI Chandigarh. So my dear friend, you have to think of 135 crore population, as our Prime Minister every time thinks of for the benefit of 135 crore population. We should also be think of where you are practicing. What is your background? Where are the facilities available? On the left side, the 5 important investigations are the absolute eosinophil count, simple TLC, DLC, and you can calculate what is the absolute total serum IgE, chest X-ray, X-ray paranasal sinuses just to rule out sinusitis and other comorbid conditions or other aggravating conditions. And of course, pulmonary function test, whatever is available, simple spirometry, from spirometry to the impulse oscillometer latestly. Then of course, you can have the facility of HR, depending upon the facility, you can do HR CT thorax, bronchoscopy, skin prick testing or allergy test, and sputum for eosinophil if test is available, because even in Uttar Pradesh, there is no center where sputum examination for eosinophil is available. So that is the condition. Yes, FANO, yes, that is also a very important investigation, but most of the centers, they don't have. Only research center, tertiary care center in this country, they have. So that's why, remember, 5 important, 5 additional, 10 investigation for the journey of approaching the diagnosis of severe asthma. Now, how to manage? Very simple. Again, you have to see whether by immunology, the Th1 response, Th2 response. So first you have to decide whether my patient is having Th2 response disease or non-Th2. So type 2 inflammation is characterized by blood eosinophilia more than 150 microliter, and or FANO more than 20 or equal to 20 part per billion, and or sputum eosinophilia equal to or more than 2%, and or asthma is clinically and allergen driven, and or need for maintenance of oral corticosteroid. So by this you can know, and now you can go for the phenotypes of asthma. A little bit simple exercise. I will go on simplifying. So you can have type 2 asthma or you have non-type 2 asthma, Th2, non-Th2. In Th2 asthma, you can have late onset asthma, usually it is eosinophilic, or you can allergic asthma where serum Ig is raised. Usually example of allergic asthma is exercise-induced asthma, late onset is aspirin exacerbated. In non-TS2 type, you can have the smooth muscle, of course, mediated paucigranulocytic asthma, that is called neutrophilic asthma, or obesity-associated asthma, or sometimes smoking-related neutrophilic asthma. So most of the time, it is neutrophilic asthma. And then, of course, you go to a very simple algorithm that is the most important treatment of the severe asthma, that is the biologicals. So what are the biologicals? So they are the recent updated agents for the treatment of severe asthma, and 3 types of biologicals are used on this base broad algorithm. You can have severe allergic asthma where serum IgE is raised. The choice of biological is omalizumab. I think most of you have heard and used omalizumab. How many of you have used omalizumab? Please raise your hands. Nobody has used? Some people are from AIMS Delhi. I think everybody has used AIM. Maybe pulmonary medicine resident, and probably they were busy in Foundation Day. So omalizumab is the choice of drug, that is anti-IgE for the severe allergic asthma. The second type is eosinophil asthma, where peripheral blood eosinophil or sputum eosinophils are high. And there you can use the anti-interleukin 5 or anti-interleukin 5 receptors. Anti-interleukin 5 is mepolizumab, and anti-interleukin 5R is benralizumab, and anti-interleukin 4 is dupilumab. So, and last but not the least is the really challenging one, neutrophilic asthma. No biological is working on that. So where you have non-TS2 type of asthma or neutrophilic asthma, your choice is bronchial thermoplasty or long-term role of macrolides. Most of the centers, most of the cities, they don't have the facility for bronchial thermoplasty. In AIMS, we have bronchial thermoplasty. In Delhi and some southern and western part of the country, we have the facility for bronchial thermoplasty. Still, for example, I'm coming from Uttar Pradesh, there is no facility for bronchial thermoplasty. You can use in these centers the macrolides. How? Very simple. Another important molecule which is primarily used for COPD, but you can switch over to the asthma also for the severe asthma. So for all severe asthma, use tiotropium for all severe asthma. If you have forget my all slide, please remember this slide. This slide is sufficient to treat severe asthma. Just take out the printout, paste on your clinic, and you will wonderfully manage the asthma. Tiotropium for all severe asthma, omalizumab or anti-IgE for allergic asthma only, mepolizumab or respilizumab and benralizumab for severe eosinophilic asthma, as I mentioned, and dupilumab for neutrophilic asthma, and bronchial thermoplasty for non-TS2 type of asthma or neutrophilic asthma. So with this, I think I'll finish within 5 minutes because more of our outline is over. So we have 3 add-on prescription for whatever the traditional practicing for the management of asthma. You have 3 choices. The LAMA, long-acting muscarinic agent, that's tiotropium, we have already discussed, low-dose azithromycin, and biological agents. So we will discuss one by one. What LAMA is doing? Its asthma is persistently uncontrolled despite ICS-LABA. Add-on LAMA. LAMA added to medium or high-dose ICS-LABA modestly improves lung function. So that is add-on part of the tiotropium. Add-on tiotropium should be prescribed in separate inhaler for ages 6 to 18 years, and it can be in combination more than 18 years. Now, azithromycin. So this is a new addition, and this can be practiced in the periphery, remote areas where facility of biologicals are not available or cost is the factor, because biologicals are costly affair. Add-on azithromycin 3 days a week after a specialist referral. So they should be used by a specialist who is trained particularly in asthma practice. So it significantly lowers exacerbation in patient taking high-dose ICS-LABA, significantly reduces exacerbation in patient with eosinophilic or non-eosinophilic asthma. And clinical practice tip before considering add-on azithromycin is that check out for the atypical mycobacteria, which is also, it is anti-tubercular also, it is working against atypical mycobacteria. So first rule out that. Check ECG because it can lead to prolonged QT interval, so that's also a factor. And cardiac patient you cannot use for a prolonged period. Consider the risk for increasing antimicrobial resistance, which is already the resistance to the macrolides. The biological therapy I have already discussed. I will not go into the details. A lot of mechanisms are there, but you can understand only three: the anti-IG, interleukin-4, interleukin-5, and interleukin-13. Interleukin-13 and other, they are in process of development. So new biological are also coming. This is a good news for those who are having very severe asthma. So I will not go into the detail of all biological, but I will just go through this comparative slide that you have omalizumab. This bind to IG, decreases expression of receptors, steroid receptor. It can be given to more than 6-year-old with moderate to severe persistent asthma. Positive skin test result or in vitro reactivity to a persistent aeroallergen. So you have to prove that your patient is having allergic asthma. Doses are, yes, 75 to 375 milligrams subcutaneously, twice a week or 4 times a week based on a serum total IG. So you require two things: total serum IG, what is the level, and body weight of the patient. And the second drug is mepolizumab, which is anti-interleukin-5. It can be used more than 12 years, 100 milligrams subcutaneously 4 times a week. The simple important side effects are headache, injection site reactions, and back pain, fatigue. Benralizumab, again a direct eosinophil, directly on the eosinophil depletion, binds to interleukin-5 receptor. It is also indicated for age in 12 years, 30 milligrams subcutaneously. Headache and pharyngitis are the common side effect. And then we have racilizumab, also similar interleukin, working against interleukin-5. So with this, I will not go into the, because this drug has not come still in India, so I will not go into, but what is the outline? Did you use biological for a longer period or you stop? Where you stop? So this is again algorithm. So depending upon the eligibility criteria, we choose the biological agent that's given for a 4 months and then review after 4 months. Good asthma response, yes, reevaluate every 3-6 months and continue. If unclear, then of course extend trial for 6 to 12 months, so maximum 1 year you can see the response. After 1 year, if there is no response, please stop it. So stop and then consider other therapies. So additional indication for these therapies in US and Europe, because they are not in India, so I will not go into that detail. So of course a little bit about the prevention of COVID, because प्रधान मंत्री जी ने कहा दवाई भी और कड़ाई भी, आप वैक्सीन लगवाते रहिए और कोविड अप्रोप्रिएट बिहेवियर को अपनाते रहिए, नमस्ते करते रहिए, मिलने पर हाथ धोते रहिए और बाहर निकलने पे मास्क लगाइए and 2 गज की दूरी बनाए रखिए. And vaccine, practice the vaccine, and don't let your asthma convert into uncontrolled asthma, because severe asthma or uncontrolled asthma is a high risk factor for the COVID-19. Thank you very much for your attention.
Thank you so much, Dr. Surya, for telling us everything that we need to know from a pulmonology point of view in severe asthma. I must submit I'm not a pulmonary physician, but being an intensivist, when we handle COVID and severe asthma, the main thing that we can use in preventing a mechanical ventilation is NIV. And when I have a patient with COVID and severe asthma, I would definitely probably not use NIV unless I have a huge vigil on the patient. Also, having said that, when we ventilate somebody with severe asthma, it's extremely difficult. We need to look at the dynamic hyperinflation, and it makes the condition extremely difficult. So a merger between asthma, severe asthma, and COVID is probably a nightmare for most of our intensivists. I now call upon Dr. Rahul Pandit, the final batsman, a very, very dear friend of mine. He's an MD, FICM, FCCP, EDIC. And to cut it short, I would just say that Dr. Rahul has been practicing as a director of the Fortis Group in Critical Care All India, and he's a very good teacher. He's excellent in making difficult things simple, and he's also got a dual fellowship in from Australia and in India. So over to you, Rahul. And I really look forward to always listening from Rahul, because he has always some new things to up his sleeve. Thanks, Ram.
Kushal, thank you very much for the kind introduction, and it's a pleasure to be here today. I must say, in the memory of late Sir K.K. Agarwal, when I was called up by IJCP team that would you like to be here, I could not say no to this. Obviously not. Can I have my slides, please?
स्लाइड्स कहाँ पे कॉपी करी थी सारी बाकी किस नाम से बैनर एंड पीपीटीज
So oxygen is obviously one of the topics. You know, we had a beautiful talk on the steroid stewardship. There is something now which is lurking around, which is called as the oxygen stewardship as well. And a lot of thought process has gone into oxygen stewardship. It's not only just when to give oxygen, but we need to look at various strategies of how we can actually minimize the wastage of oxygen as well. India went through a torrid time in the midst of the second wave when oxygen became a big problem. And we all have experiences in our hospital where we had anxious moments where the oxygen would run out, or would it be on the brink of running out, so on and so forth. And we all need to sort of learn from there that oxygen therapy is something which we have taken for granted, something which we have just understood to be a part and parcel of the whole. Thank you. Okay, that's fine. Something which we have understood as a part and parcel of a day-to-day management becomes such a big problem to go with. We also need to sort of just reflect back and go to the physiology. We had the pulmonology talk here, which sort of talked very nicely about the lungs utilizing and needing oxygen for 3 minutes. If you have a lack of oxygen, you will not be able to live. But when you actually go down to the cellular level, the requirement of oxygen drops down from each step, which we have sort of depicted here, from the air to the gases in the alveoli, capillaries, then to the arteries, and so on and so forth, to come down to almost single digits. So if you actually have very little oxygen supplied to you to begin with, your cells will starve because of lack of oxygen. Does that mean that we should give too much of oxygen? That's where the problem is. All of us want our patient saturation to be 97 to 100%. Is that what really God has asked us to do? Is that something which is absolutely necessary? So this is what we are going to look at. Now, most patients, adult patients, and I'm an adult intensivist, I don't intend to encroach on pediatric space at all, because there are some different thought processes in pediatrics, and they have very good thought processes and reasons for having those principles there. So all patients, all adult patients who are admitted and receive supplemental oxygen probably have a reason because of either a respiratory failure or a hypoxemic failure, or they may be given oxygen when they have been given some neuromuscular drugs or some sedatives, because of which their oxygen level may go down. Okay, so when we are administering oxygen, it is often careful that we give it in a way that it actually can be assessed whether it's benefiting to the patient, or we are actually going to the point where we are actually going to cause some harm to this patient. There are some clear indications for it. And some of the clear indications which I just mentioned are, if you have a hypoxemic respiratory failure, no doubt about that you need to give oxygen. Your tissue level hypoxia needs to be corrected, and I'm not going into the lactates and stuff which will actually tell you how the tissue level hypoxia is. I'm going to talk purely at the oxygen level. And sometimes when you have planned surgery, when you have patients in ICU who will be on muscle relaxants where their breathing goes down, you may need to supplement them with a bit of oxygen. This is a classic table. Whether it holds true or not is again a matter of debate. Whether you should be giving 100% oxygen to these patients, we are going to sort of learn over the next 20 minutes, 15 minutes or so, whether these principles still actually hold true, or we need to now have a toned down approach towards oxygen therapy. So before we actually venture into the therapy part, let's look at some of the effects of oxygen, which we know. Obviously, some of the effects which have been known as a physiological principle for a long time. So when anesthetists were pre-oxygenating patients, they found out that there is a bit of atelectasis which happens when FiO2 went beyond 0.6%. Also, there's an increase of right to left shunt. And we also know the Lorentz-Smith effect,
which is a known pulmonary oxygen toxicity, which we very often just tend to overlook or don't even bother about that. Similarly, the vascular system has got some effects as well. You have a decrease in your cardiac output if you give too much of oxygen when it's not needed. You also have a little bit of a bradycardia, which is tolerated by most patients. Hence, we tend to ignore it completely. And obviously, there's a decrease in the nitric oxide formation. The cerebral effect described way back, the Paul Bert's effect in 1800s, the late 1800s, where if you give too much of the oxygen, the brain actually has a toxicity to the oxygen, causing vasoconstriction followed by convulsions, or even, in fact, patients even going into a status epilepticus form of activity. And there is a bit of a cerebral edema formation which happens as well. So these are some of the effects which we have known. Then, based on these effects and the literature available, a lot of guidelines have come. We are going to just quickly revise the guidelines and look at some of their recommendations. So the American College of Chest Physicians and the National Heart and Lung and Blood Institute recommends that you should be using oxygen therapy in patients who have a cardiac and a respiratory arrest. When you have hypoxemia as by a saturation of less than 90%, or a PaO2 of less than 55 millimeters of mercury, hypotension with a systolic blood pressure less than 100, low cardiac output states, and patients who have increased respiratory distress or increased work of breathing. If you go a little bit deeper into those guidelines, you will see that they have recommendations made by various societies for individual disease processes as well. So you have a COPD, where traditionally people have tended to not use a lot of oxygen. They have tolerated hypoxemia saturations around 88 to 92% in many of these patients. Myocardial infarction, it wasn't too long ago when I was an intern, or maybe even our first MBBS, second MBBS teaching, that as soon as the patient comes in, give oxygen, give morphine. That was the teaching. We've come across a long way from there now. Cardiogenic shock, post-resuscitation syndrome. We talk a lot about post-resuscitation syndrome now. A lot of thought process has gone into making a good outcome out of a resuscitation. And I think oxygen forms a very important part of that. Ventilation patients in ICU. Obviously, one indication where you want to give as much oxygen as you can is a carbon monoxide poisoning. There is no doubt about that. So when you today has been sort of all the three talks have talked about checklists. So I'm just having a little bit of checklist as well. When you prescribe oxygen, think how basically you are able to recognize whether the tissues have inadequate oxygen or not. Think about acute oxygen therapy and what is it going to do and what dose it needs to be given as. Is the outcome of the disease going to be improved or not? How is the oxygen best delivered? Is humidification going to be necessary for this patient? Dry oxygen is a lot of problem. You give very high flow of oxygen, which is dry. You will find that the respiratory tract gets crusted very quickly and has its own problems there. Obviously, keep an eye on the dangers associated with it. And most importantly, when oxygen is not needed, stop it. Just like when antibiotics are not needed, stop it. When steroids are not needed, stop it. Stop the oxygen when it's not needed. Don't just keep on giving it. So let's look at some of the clinical efficacies of acute oxygen therapy. Obviously, when you have arterial hypoxemia, you may have three different scenarios. You may have a VQ mismatch, and the response to your therapy would depend within, how much the VQ mismatch is really. And it probably is going to be not really predictable. That's what happens when you have severe ARDS. Your VQ mismatch is so high that despite giving 100% oxygen, the response is not what you desire to have. You may have alveolar hypoventilation, and your oxygen may actually rapidly correct the problem, the hypoxia, but that's not actually the problem because of which the hypoxia has occurred. So you need to still treat the primary cause. And then you have a left to right shunt, where you may have conditions like pulmonary embolism, where despite a high oxygen supplementation, your oxygen requirements may be inadequate. What about tissue hypoxia without arterial hypoxemia? So, you have tissue hypoxia where conditions like myocardial infarction, low cardiac output state, carbon monoxide, lung diseases are there, where we are going to I'm just going to look into a little bit more detail in the slides to come through. So what are my recommendations for these problems? So if possible, always perform a arterial blood gas before oxygen therapy. A lot of times I see that patients, even now, COVID-19 patients come in profoundly hypoxic, and some of the emergency physicians may have a habit of doing a room air oxygen. So somebody who is on oxygen, oxygen is removed and then a ABG is done. If a patient comes in without oxygen, of course you do a ABG and you start an oxygen, no doubt about that. But sometimes just to get a room air ABG, you actually take the patient off oxygen and do an ABG. That's probably not required. If you know what FiO2 you are giving, you can calculate the PF ratio. And if your PF ratio is below 100, below 200, below 300, we know the ARDS net definition from the Berlin criteria clearly. Always go back and reassess the whole situation, whether you need to again repeat a blood gas or not. Hypoxemic patients are at risk of developing complications like arrhythmias. If the patient has a type 2 respiratory failure, thank you, I have one, then arterial blood gas measurements may be more frequently carried out to sort of look at the problems. And in acute stage, obviously the assessment of the response should be carried out daily by oximetry or by blood gas analysis. And your FiO2 needs to be dynamically adjusted. It should not be just left alone at one FiO2 and continued. Apart from the fire, which is not really an ICU patient complication, but it's a process complication, if at all. The pulmonary toxicity and the Paul-Bert effect I've already talked about. Let's look at some of the trials which have actually addressed this issue. We have conveniently forgotten these trials. We have not really looked into these trials, specifically in the COVID pandemic. And I really urge you all to think twice before actually starting somebody on oxygen, that whether this patient really needs oxygen or not. So the trials are in COPD, trials are in myocardial infarction, and if you look at the right-hand corner here, none of them have shown that hyperoxia means more than 100 millimeters of mercury PaO2 in your blood, has actually shown to improve outcome. In fact, to the contrary, the outcome may have worsened. Mortality may have worsened in patients who were given too much of oxygen. There are more trials to come through. The AVOID trial, which was published in STEMI patients, again, higher troponin levels were seen in those patients. Obviously, you may argue that troponin does not equate to mortality, but it obviously equates to muscle injury. And every muscle cell lost in the heart is something which the patient doesn't want to have. So SOCCER trial, which again looked at a 2-arm randomization, where they found no difference in the left ventricular infarct size, whether they were given oxygen or not given oxygen. The detox O2 acute myocardial infarction trial again did not show any difference whether patients were given oxygen or not. In post-CPR situation as well, I think patients who were not given oxygen actually did much better if it was not required. That means if the saturation was greater than 94%, you didn't need to actually go there. Stroke, couple of trials. I'm going to have a couple of trials talked about in detail, and I'm cognizant of the fact that the lunch is sort of brewing, or the dinner is sort of brewing on, and I need to quickly finish it off. But same data is coming out in the patients with stroke as well. So let's look at the major trials there. This looked at a primary endpoint on the cardiac enzymes, and they found that a larger infarct size was seen in patients who were given an oxygen supplementation when their saturation was greater than 94%. So really avoid oxygen to be given if the myocardial infarction patient has got a saturation of 94% and above. The same data was seen in the detox O2 AMI trial as well, though there was no mortality difference, but certainly the size of the infarct was a big difference. In stroke patients, this was a trial published 2017. They looked at 8,000 patients. It was a very well matched trial, no benefit with oxygen in stroke patients, perhaps some harm and some severe side effects. Again, more supplemented oxygen versus less supplemented oxygen in intensive care is something which is now coming out quite loudly. You must have heard a lot of talk about HFNOs, the high flow nasal oxygen cannulas being the oxygen guzzlers, especially during the time when we actually had an oxygen problem, and how we should be targeting our saturations in ICU differently. There are now guidelines which are looking at that. A number of trials have come across for this. I'm going to sort of come up to the major trial, the oxygen ICU trial, which came out a couple of years ago and was published in JAMA. They looked at two strategies. One was a liberal oxygen strategy. The second one was a restrictive oxygen strategy, and the restrictive and the liberal being classified as liberal being 97 to 100% saturation, and the restrictive being only give oxygen if your saturation actually went down, or you don't put 100% oxygen every time you're putting a suction catheter down, or you don't put the patient on 100% oxygen, or increase the FiO2 if you're transporting a patient to a CT scan or something. So you just maintain them on a minimum oxygen, and the results were significantly better in patients who had a restrictive oxygen strategy. There was less mortality, there was less organ dysfunction, and this is all 90 days mortality which you're talking about. A similar result was seen in hyperoxia and hypertonic saline trial, which was done in septic patients. There was a significant higher rate of side effects, including muscle weakness, atelectasis in the hyperoxia group, which was noted. So I think the evidence is overwhelming. We are using oxygen in the wrong way. We probably don't need to use oxygen in the way which we are using right now. Let's take a step back and see which patients qualify for the oxygen. Again, 36,000 intensive care patients studied in this study here. Mortality was higher in patients who had who had higher oxygen levels and higher PaO2 levels. As your FiO2 increased, the mortality increased. So again, a lot of retrospective data is also talking about the same thing. A few words can't be, the talk can't be over without COVID-19. COVID-19 and HFNO, we have sort of looked at a lot of data now for patients with ventilator. Neil McIntyre talked about ventilated patients. It touched a little bit about HFNO as well. I think HFNO is something which has helped us in avoiding ventilation in these patients. And if you look at the patient compliance, if you look at the way oxygen can be delivered to these patients, if you look and complement that with the ability of the patient to prone himself well with the high flow nasal cannula, you can obviously be assured that the compliance of the patient is much, much better. So I think one of the problems which has been our biggest detractor in the last 1 year or so is that we have taken oxygen to a level where everybody wanted to be a guru on the oxygen, nobody really thinking that we were doing more harm than any good. So my last few points would be: hyperoxia increases mortality and morbidity. Patients without hypoxia should not be given oxygen supplementation. Therapeutic use of hyperoxia should be in limited conditions like carbon monoxide poisoning. The current recommendations, and these are the recommendations which I have put in the guidelines for Maharashtra government as well. Kushrav is a co-colleague there, as well as the Supreme Court appointed committee, which we have actually suggested that, and they are already there in the ICMR guidelines. They are no different. In a monitored environment, 88 to 92% saturation is more than enough. In an unmonitored environment, 92 to 94% saturation is more than enough. You don't need to target anything more than that. As soon as you achieve your target, so if you achieve 94 in an unmonitored environment, start toning down the oxygen. If you achieve 88 to 92 in a ICU environment, go down to the lowest FiO2 so that your patient can be managed safely. Thank you very much.
Thank you, Dr. Rahul. And yes, we are running about 10 to 12 minutes late, so we will skip the question answer session. But if any of the speakers want to give any key messages, please come over to guide everybody. I thank all the speakers for giving us an amazing talk and enlightening us on the topics of COVID and the related strategies, as well as the problems that we face. I thank Dr. B.K. Rao sir for enlightening us. I thank Dr. Guleria sir for enlightening us. And I am very, very grateful to Aurobindo and Veritas for organizing Aurocon and calling us over to Delhi, which I always love coming. Thank you so much.
Yeah. I will request our President, Mr. Manish Kumar, to felicitate Dr. Khusro Beja. Honorable Doctor, it gives me an immense pleasure to deliver vote of thanks for Aurocon to all the dignitaries for attending this wonderful session. We have been fortunate to have renowned identities from medical fraternity. I would like to thank our chief guest, Dr. Randeep Guleria, who has honored this symposium with his inspirational thought. I would like to thank our chairperson, Dr. B.K. Rao, our speaker, Dr. Surya Kant, Dr. Rahul Pandit, Dr. Sanjay Kalra, and Dr. Neil McIntyre. Their deep and intellectual way of imparting knowledge have added to the glory of this seminar. I take this occurrence to thank the entire panel for representing their valuable views. A very special thanks to Dr. Khusro Bejan for moderating this wonderful session. Thank you very much, sir. Last but not least, I take this opportunity to express my sincere gratitude to our young and dynamic leader, Mr. Sharat Chandra Reddy, who is promoter of Aurobindo Pharma, and without his support and guidance, Aurocon was not possible. Dear all, more than 2,500 doctors are attending this session from 50 physical centers in all India, and similar number of doctors are attending this program through live webinar. On behalf of Aurobindo Veritas Healthcare Limited, I extend a very hearty vote of thanks to all the doctors for your valuable presence. Now I'll request everyone to please join us for dinner. Thank you very much and good night.